John has time to talk about what he was planning to talk about today. But that was great, Matt,
The
and a
stroke is more
great
important.
discussion.
Thank you all.
Be careful. I don't know if our movement disorder neurosurgeons are on the call, but John, I'm gonna give you a quick introduction, and then I'll give you the screen.
Thank you.
So John Liang is a assistant professor of neurosurgery and neurology, director of the Cerebrovascular Neurocritical Care (PRF) program, and director of the Mount Sinai West NSICU. He did his undergraduate work at Stony Brook, MD at Ross, and then the remainder of his training split between Sinai and Jefferson. John is an energetic and highly skilled neurointensivist. He's going to talk to us today about movement disorders and emergencies that warrant intensive care.
Great, thank you. I'm gonna share my screen. Okay. So, thank you, Peter. Oops, sorry, I lost my screen again.
We see it.
It's good? All right.
Yeah.
Yeah, so we're gonna talk about movement disorder emergencies, which is something that is not commonly thought of or seen, but it is worth discussing because we see these once in a while. So to summarize, movement disorders, we kind of broadly characterize them into two different categories, right? You're either hyperkinetic or hypokinetic movement disorders. Then you also have the progressive and neurodegenerative. Think of your typical Parkinson's, right, where you have Dr. Gopal come and do DBS and all the movement disorder outpatient. Then you have the acute movement disorders, right, where hopefully you'll be calling one of our graduating fellows to come and help. So let's start with a case. Here is a 63-year-old gentleman with history of epilepsy who's admitted for EMU for seizure monitoring. RT is called this morning for exam change. History has diabetes, hypertension, had a prior stroke 20 years ago with a spastic right hemiplegia, also has a right BKA from peripheral vascular disease. So on exam, this is what we see. He's awake, he's alert, oriented to time, place, person. He's fluent, he can speak, he can follow commands. You see the baseline right hemiplegia, that's spastic. And he just has these movements on the left side that's a little hard to control. And so that's what we have. Any thoughts from the residents on what's going on or what's happening? Is this a seizure perhaps?
Kind of looks like he has hemibolism, at least at the beginning, on the left upper extremity there.
Yeah, spot on. So what do you think is going on for what causes hemibolism?
Usually a lesion to the STN, subthalamic nucleus.
Perfect.
Isn't much going on.
Yeah. So exactly, hemibolism is lesion to the subthalamic nucleus is the classic teaching in all the case report. Although now we kind of know that it kind of can be other places beyond the subthalamic nucleus. It can, usually subcortical, but there are even case reports of it being cortical parietal lobes. Good. And here's a different patient who has something similar. It was his hemichorea, kind of felt to be on the spectrum of hemibolism, but a more milder form perhaps. And it looks like these dance-like movements. And if this gentleman had a left caudate hemorrhage, which is what's resulting in the hemichorea. All right. Here's another gentleman, 37. Once again, everyone goes to EMU for these. But over the last few days, he's becoming more delirious, started having some abnormal movements, which I'll show you. His history, he's diabetic. He had history of kidney transplant. On exam, he's awake, alert. He has this similar hemichorea movement. Here's his MRI, DWI, T1 a little hyper intense, and T2 flare. What are your thoughts on what's going on here? All right. Can I pick on you again, Dan?
Yeah. To me, it looks like he's having, once again, a hyperkinetic, chorea on the right side. That's what it looks like to me, right-sided chorea, sort of stereotypical movements. And then on the imaging, I see a a flare hyperintense lesion in the left caudate. Yeah,
Yeah.
non-diffusion restricting primarily.
Right. Yeah. So not a stroke per se. So this gentleman actually was in DKA, and all this is from hyperglycemic hyperosmotic injury. And that is usually the second differential in hemichorea hemibolism. If it's not a vascular problem, most commonly it's a hyperglycemia issue. And these cases, for both, they generally improve gradually with time. The hyperglycemia patients tend to resolve faster and better once the sugars are under control. Treatment for these typically is antidopaminergic drugs. We use Risperdal, Haldol. In extreme cases that are very refractory, we may use tetrabenazine, which is the medication we use for Huntington disease. It kind of prohibits the reuptake of dopamine in the in the synapse, and then therefore depleting the neurotransmitters at the synapse. So these are common ways we manage hemichorea hemibolism. So going back to this gentleman who had the stroke in the subthalamic nucleus, we treated it with aspirin, statin. We did the whole stroke workup. We started some Haldol, and there was some gradual improvement in the hemibolismus over the course of 2 weeks. Why is the patient still in the hospital for 2 weeks? We're waiting for rehab. And then over the last 2 days, he's on the floor. The nurses call you. It's getting less and less responsive, gradually, having high fevers. The tone is increased throughout. He's a little tachycardic, hypertensive. And you're called again. Anyone else want to take a stab at what's going on here? See. There. I'm gonna randomly, maybe honestly, can I bother you to see what your thoughts are?
I mean, it looks the same as the other
Oops.
cases that we've talked about. Looks like he's got some left upper extremity hematopolism. But, I mean, there's an exam change, ischemic stroke. It could be a stroke, I guess.
Yeah. What do you think about the, fever and tachycardia and how would you normally respond when, any of your floor patients are kind of displaying these signs and symptoms?
Well, he's on that Haldol, right?
Yeah.
So maybe he has like NMS.
Yeah, he definitely does. Good. So moving on. So he has NMS, as honestly said, right? The name kind of gives you a clue on what's going on. Neuroleptic is usually a class of medications for psychosis. They tend to be antidopaminergic. Malignant Usually, if you don't treat it, you could die. And syndrome is a group of commonly seen signs and symptoms. Normally, we talk about rigidity and fever as the main things, and then a lot of altered mental status and dysautonomia. The DSM-5 criteria, as you see here, you must have rigidity and you must have a high fever and you must be exposed to a dopamine blocking agent. And then any of these two criteria below. The thing that most people really notice and see is a lot of altered mental status, which could be from simple delirium to coma and catatonia. And they're very labile. The blood pressures go up and down, very tachycardic, tachypneic, things like that. In the past, it was, first described in the 1950s when they were using Thorazine and they described it as a side effect to Thorazine. Nowadays, we know that it can happen in non-neuroleptic also. So even though the name is neuroleptic malignant syndrome, we can actually see it in a lot of non-neuroleptic medication. The common things that we may not think about, I kind of highlighted. Reglan is a common offender, and compazine is also common. So for antiemetics and that we normally give to our patients, they do run the risk of causing NMS, and obviously all the psychiatric meds. Classic vignette: young male with psychosis gaining hollow is the classic board vignette. However, now we do know that it can happen in all ages and any gender is at risk. There's no preference for males or anything like that. And it is actually more common in the elderly nowadays. So, and the question is like, why? And I think we're many more elderly patients, and a lot of times when you're in the hospital, many elderly patients, for one reason or another, tend to end up on some Seroquel or Zyprexa for agitation or sundowning or something like that. So these are something that we do see and should consider. Mechanism of action, a little unclear, but we know it's all related to dopamine. All the meds in one way or fashion blocks dopamine or decreases the dopamine. And when it goes to the hypothalamus and the central dermal regulatory centers, you can have all the hyperthermia. When it goes to the nigrostriatal pathway, you can have all the rigidity and tremors. When it goes to RAS, you have alertness problems, and all systemically, it all interconnects with the dopamine receptor, the D2 receptors. The classic first generation antipsychotics have much higher affinity, so your Haldols, and your second generation antipsychotics have less affinity for the D2 receptor. So there is a trend that the more commonly used antipsychotic nowadays tend to have a milder course of NMS. Overall, in summary, NMS, tetrad, right, hyperthermia, it's not uncommon to have really, really high temperatures, not uncommon to have lead pipe rigidity. You can have dysautonomia, altered mental status. It's a subacute onset. It doesn't happen overnight. It's usually gradually onset within 1 to 4 weeks of exposure to a offending agent. And when you take it away, it takes about a week or two to really resolve everything. Slow on, slow off. Management, usually when it's mild, benzos are the way to go to calm the system down. If it's more severe, we do use bromocriptine and amantadine, right? Bromocriptine acts as a agonist on the D2 receptors, and amantadine increases dopamine release from the nerve endings, and that's the mechanism of action of these two agents, that basically increasing the dopamine. And in severe cases, you would use dantrolene. It's severe when you have rhabdomyolysis or hyperthermia from ongoing muscle contraction. We can also do ECT. That would be extremely last kitchen sink type situation. And then most of the time we bring them to the ICU for supportive care, right? Supportive care, basically all the complications that occur is a result of, whether it's obtundation, you can have aspiration, dysautonomia, you have a lot of arrhythmias, rhabdo, you go into renal failure, you can get PEs, DIC. So you can see the whole gamut of things that we would normally be doing in the ICU for these patients. But the key thing is to stop the offending agent and recognizing the syndrome before it gets too bad. I would be remiss if I didn't talk about Parkinsonism hyperpyrexia syndrome. This is considered to be part of the NMS spectrum. It's really when a Parkinson's patient who's been taking dopamine meds all of a sudden have withdrawal of those medications from their system. And symptoms can start, under 24 hours of missing dosages. And they do recover faster and have better prognosis than MS as long as you give them their medications. And really, it should be on the differential for any fever unknown origin in a Parkinson's patient, right? The classic scenario, a long time ago, they used to do these drug holidays, which is outdated now. So, when Parkinson's patients, they are under dopamine medication, they get a little psychotic. What used to happen was the neurologist would stop your medication, kind of put you on drug holidays to battle the psychosis. And that is a setup for this. Rapid switching or dose adjustment to any of the Parkinson's meds, or the Parkinson's patient has some cognitive impairment, they are missing dosages at home. And probably one of the things that can happen is incomplete MedRec on admission, right? These people have a lot of medications. They're taking it 3, 4, 5, 6, 7 times a day. And you can imagine if they get admitted, they're altered, they don't have their meds, no one's here to tell you, you may not give them their proper medication, right? They come in for DBS and post-op DBS, if for whatever reason we don't have the proper MedRec on file, they are a setup for having this issue. So MedRec is very important for all the Parkinson's patients. Treatment is really just to give them back the dopamine. And, in cases if they're too drowsy post-op and they can't take it, they may need an NG tube, or they may need an oral disintegrating tab just to get the dopamine in them. All right. One more case. 64-year-old guy, hypertension, hyperlipidemia, bipolar, came in with a left basal ganglia hemorrhage. Dr. Kellner comes in, right, does the usual 99.9999% evacuation. Great post-op imaging. And then post-op day 1, he's on Precedex. He's a little bradycardic, so we try to pull down the Precedex. Extremely agitated, climbing out of bed. So we put him on fentanyl. We gave him some Haldol. He has some home meds, some Depakote and olanzapine that we restart for symptom management. The next day, you can see the fever all of a sudden shoots up really high, 103. He's once again agitated, trying to climb out of bed. He's on bilateral wrist restraints, trying to self-extubate. Blood pressure is in 150, tachy, sweaty, white count is climbing. So what do you think is going on in this case? Yeah. I have Emily, can I bother you? So you're first on my screen.
Yeah, so in this gentleman as well, the very high fever in the setting of having received Haldol